Thank you for joining us for our monthly lunchtime webinar. If you haven't set up your audio, please follow the instructions on the screen and do that now. My name is Karin Shaw. I'm with the UCLA School of Public Health Office of Alumni Affairs, and I will be your moderator today. The idea behind these webinars is to open the classroom to our alumni and friends, to give you the opportunity to hear the latest research and thinking on critical public health issues. We very much want this to be a discussion, so we will allow about 30 minutes for questions after the lecture. Let me give you just a brief tour of the Illuminate program we are using. In the middle of the left-hand portion of the screen is a text box where you can type questions either as they occur to you during the lecture or during the question and answer part of the webinar. You can also click the emoticons, the smiley face or confused face, to give us feedback during the lecture. Dr. Richard Brown, the founder and director of the UCLA Center for Health Policy Research, was to have given our webinar today. Unfortunately, he is unable to join us, but we are delighted that Dr. Stephen Wallace is filling in. Stephen Wallace is a professor at the UCLA School of Public Health and an associate director at the UCLA Center for Health Policy Research. He is a leading national scholar in the area of aging and communities of color. In this webinar, Dr. Wallace will discuss how data and analysis are used by policymakers and advocates to develop evidence-based public health and healthcare policy. So let's get started. Dr. Wallace.
Sorry, I didn't have my microphone on. I hope you can hear me now. So I want to thank everybody for joining us and send the apologies from Rick Brown for having to be called away at the last minute. So what I'm going to be doing is going over the presentation that he prepared, and there's the outline is up here. So what we're going to talk about today is how we can put data and analysis together to improve the population's health. Well, this is really based on the experience of the UCLA Center for Health Policy Research, which has as its core goal to promote evidence-based health policy. A lot of policy gets made in the United States at the federal, state, and local level. Sometimes it's just based on anecdotal evidence, on disasters that happen, but having good solid evidence to design health policy is particularly important, and so the center has been at the forefront of doing that for the last 15 years. What I'm going to talk about in particular is the California Health Interview Survey, which has been developed particularly for California as a relevant data source for health policy making. And what I'm going to talk about is a little bit about the California Health Interview Survey, some about how we have developed channels of communication and dissemination. A lot of research gets done in this country that ends up in academic articles, but doesn't end up in the hands of policymakers and advocates. And so we've developed a number of tools, a number of strategies for putting information into advocates and local agencies to enhance their ability to use the data and research that we provide, and disseminating this to those audiences. So let me get started. So as I mentioned, the key goal of the UCLA Center for Health Policy Research is to promote the development of evidence-based health policy. And by that we mean to put empirical research into the hands of policymakers, advocates, people who are making and influencing policy, so that the decisions that they make are based on an accurate portrayal and an accurate understanding of the health risks and health services that face California's populations. The first step is to get that data and to put it into the hands then of policymakers and advocates. We talk about this as translating research into policy. Data doesn't talk for itself. We can pile lots of information on the desks of policymakers and it's not going to get used. So we really have to translate the research into something that's policy relevant. Well, that requires a strategic approach to both thinking about the research and the data and to getting it into the hands of policymakers. We talk about this as democratizing access as well, because we're not only focusing on large organizations or large government agencies that have a lot of data analysis capacity, but we're really trying to put the data into the hands of community members as well, and some of the smaller governmental agencies that might not have the capacity to take a data set and run it in SAS and do all of the transformations necessary. So by democratizing access, we're putting the data in a format that can be used by a wide variety of policymakers and key stakeholders. The center has developed a strategy for doing that, which both encourages and supports the development of evidence-based health policy. First, we are developing population-based data that provides information about diverse populations in geographic areas. There's a lot of data that exists in a number of organizations at the state level. That is clinical data, there's hospital discharge data, there's data from clinics, there's birth and death data. So there's lots of data that's floating around. The strength of the California Health Interview Survey is that it is based on the entire population of people living in households. So you really can generalize from the data. And in California, as everybody knows, we have a very diverse population. So we specifically target the data that we're collecting to reflect the diversity of the populations. I'll mention how we do that in a minute, as well as the immense geographic differences from Northern California down to the border with Mexico and areas in between. We then need to get that data into the hands of people who can use it, and so we've developed targeted channels of communication and dissemination. And we've thought about the users at a variety of levels. So we're not trying to do a one-size-fits-all, but we really have different mechanisms for getting data out to people depending on what their level of technical capacity is. So that's number two. Number three is to try to enhance the capacity of both advocates and local health departments so that they can use more complicated data and customize the data that we have to fit their needs even more effectively. And then finally, we're trying to promote the use of this data in a number of formats and to disseminate it broadly to different policy audiences. And over the last 10 years, these have proved quite effective in reaching policy audiences, community health agencies, and have had a demonstrable impact on public policy. Just as an aside, so Rick Brown, who was called away at the last minute, founded the California Health Interview Survey, and I've been affiliated with it since the beginning, and it's very gratifying to see as an academic work that you do show up in public policy and have a visible impact within a relatively short amount of time. So we'll talk a little bit more about that. The California Health Interview Survey is of the highest scientific quality, and it covers, as I mentioned, diverse population and geographic areas. It's actually 3 surveys which are coordinated. There's an adult survey, which is ages 18 and over. There's an adolescent survey, which is 13 to 17, and a child survey, which is 12 and under. And the survey itself is a household level survey. So we contact a household, we randomly select one adult, and then if there is an adolescent in that same household, we randomly select one of the adolescents and one of the children. So we have information potentially about 3 members of the household. But what's important about this is we have household level information then about the adults, the adolescents, and the children in that same household and the contextual data within that household. When we're designing the survey and the design of the survey, we're specifically thinking about how the information can be used to support policy analysis, as well as policy advocacy on health status, health care, and determinants of health, both at the level of the state of California, but even more importantly at the local level. What's interesting is there's a lot of national data on health status, but California both leads the nation in a number of aspects and is much more diverse than the nation as a whole. So looking at national health trends only gives us a suggestion about what's going on in California. California itself, however, is also incredibly diverse. So even if you know about trends in California, you may or may not know about the trends in San Diego County or Ventura County. And you surely don't know what's going on in Humboldt and the Sierras if you only know about statewide trends. So the California Health Interview Survey has spent a lot of time and effort to provide local area estimates at the county level in most cases. In some of the sparse counties, we do combine them to more of a regional area. And in Los Angeles and San Diego, we have sub-county data, which is very important for planning and analysis purposes. This all helps us understand and measure the health needs of California's population, as well as to assess disparities in health and health care across the population. The survey, the design, the questions, and the administration is guided by a series of work groups and advisory committees that draws on more than 140 individuals from 60 diverse organizations and agencies, community-based agencies, agencies in the state health department, other state agencies, funders, of which we have 7 major sustaining funders, including both private organizations and public agencies. So there's a wide group of stakeholders that informs the development of the survey, which is our way of making sure that we're responding to both upcoming policy developments and making sure that the contents and the way we're delivering it is relevant to the key stakeholders throughout the state and at every level, from community organizations to clinics to government agencies and so forth. The way we collect the data is through, as it says on this slide, a very large telephone survey of the California population. The California Health Interview Survey is actually the largest state health survey in the country. We collect information from around 50,000 households. It does vary from year to year, but it ranges from 45 to 55,000 households. And as I noted before, there can be multiple interviews within that household. It covers a wide range of public health and healthcare topics. There is a core set of topics that are asked every single round of the California Health Interview Survey, and then there are supplementary topics that sometimes are added and sometimes go. I know my work is on older adults, and there have been questions on falls among the elderly 3 times now in the last 6, so sort of every other administration. It has been administered every 2 years, so starting in 2001, 2003, 2005, 2007. The 2009 data was just released last month, and we are heading into the 2011 survey. I actually don't think this is listed here, but we are moving from a concentrated data collection period every 2 years to what's called a continuous survey, which means that we'll be collecting 1/24th of the sample every month over 2 years. And that actually was partly in response to the need of policymakers for data that responds to today's situation, which may or may not be the same as the situation in the state during the last concentrated data collection period. So for example, we collected data in 2009. The worst of the recession hit after 2009. So there were a lot of questions about what happened to health insurance as people were losing their jobs. But because we were in between survey administrations, we had to use a variety of analytic strategies to come up with our best estimates of what was happening. With the continuous survey, we'll actually have data every single month of the year, and when circumstances change, such as recessions, a particular new policy that's put into place, such as healthcare reform, that hits on a specific date, we'll actually have continuous data, and we can break the data at any particular point and be able to look at before and after effects of that policy. That was a little sidebar. The survey is conducted in 6 different languages. It's conducted in English and Spanish, and then it's conducted in 4 Asian languages: Mandarin, Cantonese, Vietnamese, and Korean. The 4 Asian languages actually are, I don't know if it's unique, but it's very unusual in large surveys. We're fortunate to have large populations that speak each of those languages in California. And because of the language diversity that is included in the California Health Interview Survey, we are the only non-federal survey that's used in AHRQ's annual Health Disparities Report. So that is a good indication of the significance of being available in language. I mentioned already that we have our sampling frame allows us to do county level estimates. Los Angeles and San Diego has sub-county areas. And as it notes on the slide, we also, several years ago, started a cell phone user panel. As many of you know, I'm sure many of you have experienced this, more and more people are dropping their landlines at home, which was the traditional way of sampling households, and have become cell phone only households. And so we have a significant and each cycle growing panel that is based on cell phone users. And we've done a number of methodological studies of that group to make sure that we're accurately representing the entire population. Finally, the data that we have, because it is of households, we do ask, and most people provide information on their location. And so we're able to map where people live, and therefore we're able to associate the data from those individuals with other social and physical environment data, how far they are from a freeway. We've done a number of studies of asthma and distance from freeway, which we can do because we know how close people are to major freeways, how far they are from the nearest community clinic, how far they are from the nearest park, if they're in a neighborhood that has concentrated poverty, and so forth. So the information in the survey includes both the questions that we ask, but then also a number of contextual pieces of information as well. How many people here have used the California Health Interview Survey? Click on the little clapping hand so that we can see how many of you have ever used CHIS. I see 1, 3. It says 5 of 45. So I take that to mean that most people have not used the California Health Interview Survey. Okay, so let me tell you just a little bit more about what is in the survey, because that's important for understanding its usefulness for policy and advocacy. The survey is about a 30-35 minute long telephone survey. It includes extensive sociodemographic information, including race, ethnicity, nativity, where you were born, how long you've been here if you're an immigrant, language use in household, income, home ownership, those types of sociodemographic variables. It includes a large section on health risks, health behavior, including issues like body mass index, tobacco use, alcohol consumption, physical activity, diet, nutrition. It includes information on health status. We ask about a number of chronic health conditions such as asthma, diabetes, which are major chronic conditions, heart disease, and so on. And then there's a big section on health insurance and health services use, including access to care, very careful information on health insurance, which is an incredibly complicated topic to try to determine both what types of health insurance people have and then also what kinds of health insurance people might be eligible for. information on physician use, communication with their physician, and emergency room use. So it's designed as a surveillance survey. It's broad. It goes deep into a couple issues, such as some of the cancer issues, but it does try to get a broad spectrum of information about the California population. So once we have all this information, we want to get it into the hands of people who can use it. It doesn't help improve the health status of Californians if it simply sits on our website here at the Center for Health Policy Research and is not being accessed. So we've segmented the types of users to try to identify the best way to reach them. Some of the users we're trying to reach are policymakers and their staff. So policymakers are often very busy people. Their staff are generally generalists and not specialists, and they often have limited technical resources and even more often limited time to access and analyze data. So they're on the run, they're addressing policies that are coming through fast and furious, and they don't necessarily have the time to sit down and play with data for days at a time to answer their questions. Second audience that we have are advocates, especially advocates that deal with low-income and vulnerable populations. They often have limited technical resources, so they may have a little more time, say, than a legislative staffer does, but they may not have the technical capabilities to use public use data, and so they need information in a slightly different manner as well. Local health departments and community-based agencies sometimes have limited technical capacity as well. I know, being in Los Angeles County, which is a huge county, almost 10 million people, the local health department here has plenty of technical capacity. But in some of the smaller counties, Humboldt, Del Norte, even some of the medium-sized counties, in the Central Valley, for example, or Monterey, may not have the types of people who have backgrounds and degrees in epidemiology and biostatistics to do the types of analyses that a Los Angeles or an Orange County might be able to do. So we want to make sure that local health departments are able to use our data throughout the state. And finally, populations of color in some smaller local jurisdictions often find little data about their group or about their geographic area because the population size is small. And so once again, we want to be able to provide information that is usable to those groups. So to develop targeted channels of communication to reach each of those, we have developed an extensive dissemination strategy to maximize the use of CHIS data. What's particularly impressive, I think, is that we spend about 1 in every 5 project dollars for the California Health Interviews Survey on dissemination. So we spend a lot of money on developing the survey and on collecting it, but we also put a major portion of our resources into getting that information into the hands of people who can use it. So the easiest way to access CHIS data, the most basic and most usable way, is through Ask CHIS. So I asked how many people had used CHIS data before. So let me ask you to, if you see a little clapping hand sign, clap your hands if you've ever used Ask CHIS. I feel like I'm doing public radio. I've got about 6 people on the line. All right. So only about 15% of the group here has used Ask CHIS. How many of you use the clapping hands again? Have visited our website, the www.healthpolicy.ucla.edu? Clap your hand. So a few more. Okay. This was actually on slide number 1. So if you want to get your pencil out, because it's easy to remember, but it's not entirely intuitive. The website for the Center for Health Policy Research is www.healthpolicy, one word, .ucla.edu. And on the homepage of the website, if you go down to about the middle of the homepage, there is There are 6 areas that we feature in the center, and one of them is the California Health Interview Survey. If you click on that, it'll take you to a screen that gets you to Ask CHIS. And the little button that you see on this slide actually brings you into the Ask CHIS data query system. This is free. It says statewide. It's actually it's free to access statewide and local data. It's available over the internet, so we actually have users overseas as well. We do ask that you register so we have a sense of how many unique users there are and a little bit about who those users are. But once you fill out the basic information on who you are, the use of the system is unlimited and free at any time. What this lets you do is it lets you create user-defined analyses from CHIS data from all the surveys. So the data from 2001, 3, 5, 7, and 9 is currently available through the system. What it actually does is it does part of your work for you. You have to decide what you need, but then when you say, I'm interested in a crosstab of the number of people in California with diabetes by race ethnicity, you go through and you click on diabetes, and then you click on race ethnicity, and the program that you don't see actually writes computer code in SAS and runs the data and then presents you with the table. So the hard part is done by the computer, or the technical part is done by the computer. You do the hard part, which is to decide exactly what the information is that you need. The computer does the technical part and replies with the data about the population in California with diabetes by race and ethnicity. It gives you both rates as well as estimated population total. So you can say that there are X million Californians who are Latino with diabetes. It lets you drill down to the smallest levels available on CHIS, so that would be county level in most cases, SPA and the equivalent in San Diego and Los Angeles. You can do subsets to data, so if you're only interested in Chinese immigrants, you can go and you can say, I only want people born in China, and so forth. So it's actually a very powerful and been designed and refined over the years to be a very user-friendly way of accessing CHIS data. We currently have 27,000 people who've used Ask CHIS. About 8 of them are on this webinar. And in the last year alone, they've run over 94,000 queries. So 94,000 tables have been created for an average of over 250 a day from people using Ask CHIS. And typically that goes up with the new data. So in the next couple months, there'll be a spike as people are looking at the 2009 data. And this is used by policy staff, advocates, media, researchers all across the board. I use it when I teach some of my classes. I have students create queries using Ask CHIS. The second way that we do this is make the CHIS data available to all researchers through public use data files. So on that CHIS data site that I pointed you to earlier, there is a way to actually download the raw data. Now it is created in a way to protect the respondent's anonymity. So on the public use data file, there is not a county identifier, because it was determined that if you knew that a person lived in Solano County and they were 20 years old and a Latin American immigrant, and they had 3 kids in the household, and et cetera, that there was a chance, however remote, but some chance that you might be able to sort of figure out who that person was. So the public use data that you can download and actually work with the file is available only for statewide analyses. Also on those pages, they have the complete questionnaires. There's methodology reports, which gives you extensive information about the quality and the design of the CHIS data. And then it also includes information on the third way to get CHIS data, which is through the Data Access Center. The Data Access Center allows you to access confidential levels of data such as the geocoding or county IDs. But to keep the information confidential, the data itself can only be accessed by CHIS staff. So there is a protocol for you either requesting specific runs or for you actually writing SAS code if you want. Our staff does the runs and then provides you with the information. So there's 3 levels of ways of accessing CHIS data. CHIS data. Ask CHIS, which is the on-the-web interactive, extremely user-friendly. If you know how to use SAS, SPSS, or Stata, you can download a public use data set and look at most of the variables at the statewide level. And then you can access some of the confidential data through the Data Access Center. And I see the moderator has put up the URL for the homepage. Thank you. Andrea wants us to please repeat the process to access AskCHIS on the site. Okay, so for AskCHIS, you go to the homepage, which is the www.healthpolicy.ucla.edu that the moderator put up. On that homepage, if people actually want to open a new window, you can see about halfway down on the left, there's a box that says California Health Interview Survey. You check that box and it takes you to the CHIS website, and then you can see that little button that says Ask CHIS. If you have any questions, you're welcome to email as well to the center, and we do provide technical assistance. Now, the other part of this, which is next on this slide, except I just lost my slides. If you'll hold on a second. Okay, so that was the window that's, hold on a second, in trying to show you. No. Sorry, I opened a new window here, and I think I logged off. So while I'm re-logging on here, if everybody can still hear me, I can, let's see, tell you a little bit more about
recording in progress.
Okay. So now I've got an echo. Oh. Sorry about the technical difficulty and the echo. One of them. How's that? Is that okay? All right. Sorry, this is what I get for trying to...
Well, I'm confident that you'll be logged back in shortly. So if you would like to type up some questions that might have come up until now, please do so in the text box. And usually it takes just about 30 seconds to log in. So I'm hopeful that we will be back with our presentation very soon. Thank you for your patience.
Hi, this is Steve. Can you hear me now? Thank you. So I can't hear me, but it's showing that it's transmitting. So you turned off the primary one and there's just a secondary one.
Okay, good. Okay, now you can.
Okay, can you hear me now? Yeah.
Yes,
Okay.
yes, we can hear you.
All right, thanks. I couldn't hear me, but so I wasn't sure if you could or not. All right, so I apologize for that. So does everybody know how to get onto AskGIS now? Was that worth the diversion? Okay. So let's keep going. So there's a program in the Center for Health Policy Research called Health Data, which is the data advocacy and technical assistance, which is designed for helping people turn knowledge into action. And we do a number of trainings that works with local agencies and advocates to help them better understand data and how to use it in the policy advocacy and planning process. We conduct workshops in a number of regions around the state on both how to access health data, about how to ask questions about the data quality and validity, and how to apply research data in their programs. If you are interested in learning more about how to use the AskGIS online system, we also run a series of online trainings similar to this webinar, but specific to using AskGIS. They're 90-minute to 2-hour online trainings, and I would encourage you to go to the homepage of the website, which is the www.healthpolicy.ucla.edu, and in the upper right-hand corner, you'll see a join our email list for our newsletter, and that will give you information both when we schedule online trainings for AskGIS, as well as a lot of other useful information about center reports and other activities. We also have a series of researchers at the center who are busy conducting analysis and disseminating data from GIS on a variety of issues. We have researchers who are experts in health insurance and access to care, including access to cancer screening, mental health, as well as the broader health insurance issues. We have researchers who are doing work on social determinants of health, disease, and health disparities. A number of researchers have done work on health behaviors, particularly food choices. There's a lot in GIS on fast food, on 5-a-day, on food security, on physical activity, sexual behavior. There's a whole module that asks about sexual behavior and safe sex, and other determinants of both transmissible as well as chronic diseases. There's work that's being done on the management of chronic diseases and health behaviors of both children and adults. So it's across the entire life course. So so I mentioned the 3 ways of getting AskGIS data. There's actually a 4th way, and that's through our publications. And the publications provide a lot of data in the form of tables, but also analysis that stimulates policy discussion and helps policymakers and advocates think through solutions to some of the pressing health problems of the state. The ways that we disseminate information are through research reports. These are all also available on the website. The website is sort of your key window into the Health Policy Center. And there is a a section for publications there where you can search by topic, by author, and the most recent ones are highlighted at the very top of the website. Research reports are more in-depth. They tend to be 20, 30, 40 pages with a lot of data in them. And as Rick has put here, to meet the needs of policy wonks. So people who really want the details and lots of background information. The policy briefs are shorter. They're between 4 and 8 pages. They're more focused. They typically include a couple of tables of data that really sort of introduces the information. And then we've got fact sheets, which are 2 pages, which are really on a topic, like how many people are insured or uninsured now, how many people have diabetes according to the latest data that we have, and puts key information right into the hands of people who need it. So to get those, the best way is to get on our listserv. We do a monthly newsletter that informs you of new publications, of when new CHIS data and other types of data are available that the center collects, when there are trainings from the Health Data Program, and on an ad hoc basis, once or twice a month additionally, sort of breaking news from the center. The center also works very closely with the news media, and I almost guarantee you that you've read an article in the newspaper or heard a story on television or radio news that's based on CHIS data. We are constantly being referenced either for reports that we've released or as background information in news stories around the health of the California population. So, how has some of this had an impact? Right now we have a healthcare reform work group in the center that brings a number of faculty and staff together to really look at some of the implementation issues around healthcare reform and how we can use CHIS data and the resources of the center to provide for the best implementation in California. And the California Health Interview Survey, in fact, is both the official and really the primary source of information for the state of California in its design of the health insurance reforms that are being implemented as a result of the new national legislation. The governor relies on CHIS data. State agencies both help fund and extensively use CHIS data. The legislature often cites CHIS data in some of their findings when they're writing policy. And all of this is being used, like I say, in healthcare reform. It's been used in the State Department of Public Health diabetes program, looking at prevalence and management at the county level around diabetes. CHIS data has been used by advocates, maybe most notably in the policy arena around the issue of food insecurity. And a couple years ago there was a report that was released by the center that looked at food insecurity that was used both at the state level and at the county level in Los Angeles to enhance access to food stamps as a way of trying to reduce the levels of food insecurity that were shockingly high. And that data both motivated and helped policymakers design where they were moving with that. We've also collaborated with advocates. So, okay, so I mentioned the food insecurity. We've also collaborated with the California Center for Public Health Advocacy. There have been a series of reports recently on the food environment around sugary drinks, which has helped prompt some soda bans. There's been some reports on the density of fast food that's led to some local zoning changes. And the Center for Public Health Advocacy has taken CHIS data and really run with this in the policy arena and had some very notable success in that. I see, thanks to my 5 minutes of slipping around with the internet, I'm almost at the end here. CHIS is also used by nonprofit funders. The California Endowment is a major both investor in CHIS and user of CHIS in developing specific initiatives. As you may know, they have a 14 community investment strategy currently, and they are using health information from CHIS to both help those 14 communities prioritize the areas that they're trying to make changes in, as well as to evaluate the impact of their investment in those areas. Another example is Kaiser Permanente, another investor in CHIS who is an active user of CHIS. They use CHIS data constantly to understand their local communities around where their facilities are and to help them target their community benefit funds to make the greatest impact in their service areas. Those are a couple examples of how some nonprofits have used our data. It's used extensively and widely by a whole range of public agencies and private organizations around California. Recently we learned of 2 clinics in the Central Valley who use CHIS data to apply for and succeed in obtaining several $1 million in new funding for their community health centers to provide better services in their area. We've conducted a survey of CHIS users, and it's impressive to see the policy advocacy, the program planning, the program development uses that CHIS data has been used for throughout the state. And we've got about 10 minutes left, so I should probably open it to questions and answers at this time. And I'll just offer as a warning that since I'm not Rick, he knows everything upside down and backwards about CHIS. I only know things forwards and right side up. So you may ask some questions that I don't know, and I will pass those on to him and he can get back to you. So let's see. Karin, I think you were going to moderate questions and answers?
Yes, thank you, Dr. Wallace.
Yes, thank you, Dr. Wallace.
As you said, we have about 10 to 15 minutes for questions. So if you simply type your question in the text box, and then Dr. Wallace will answer them in the order they come in. I have one, maybe just to get us started. Which other states have surveys like CHIS?
So what's interesting is California, I mentioned earlier, is a leader nationally in a number of different ways. We're a leader nationally in the development of state health surveys. There are 3 other states that are doing similar surveys, Arizona, Texas, and Illinois. Each have surveys that are somewhat similar to CHIS. They're comprehensive, population-based surveys that look at a variety of health issues. Ohio and Iowa are 2 states that currently have surveys. They're looking to expand them into more of a CHIS-like model, and there's a number of other states, another say half a dozen states that are in various types of planning processes to be able to develop these types of state health surveys. We're also really pleased that we've had an interest by a national foundation which may fund us to develop a state health survey network of organizations across the country so that we can help provide technical assistance to other states who are designing similar types of health surveys, help them so they don't have to reinvent the wheel, so to speak, and be able to develop these as a true network of state health surveys nationally. It looks like, let's see, copy the PowerPoint. I think that's not a problem. How do you collect geocodable information? So when we do a interview with an individual, we ask them for the nearest cross street. So if you had called my house, I would say the nearest cross street is Sepulveda and Braddock. Now it's about a block away, so it's not the exact address, but that's the nearest major cross street. That then gets longitude and latitude coded in the confidential data set, so that if you wanted to know how far my house was from, I'm a Kaiser member, from the nearest Kaiser clinic, you could then take that point and using a GIS system say, he is approximately 2 miles from the nearest primary care provider. And I personally have used that and some work with looking at immigrant health and looking at people who go to Mexico for health insurance, for health care, and looked at how far they were from the border. So you can take their cross street and then once again using a GIS program say that my house is 135 miles from the Mexican border. So those are the types of ways that you can use the geocoded data. You can also then, based on that, assign me a census tract. We also do ask the person their zip code, and there is census data and other types of data that's available at the tract and the zip code level, which you could use as part of the analysis. Will CHIS ever have a component regarding emergency preparedness? That is an issue that comes up. That's been a priority off and on of different levels in public health departments. The way that the topics are decided for CHIS are based on a combination of core items, which we ask every single time, and then the major funders, the California Department of Public Health, the California Department of Mental Health, the National Cancer Institute, the California Endowment, and not to slight any, there's 7 major funders. I've mentioned 4, First 5 is a major funder. Oh, and I apologize to the 2 that I have forgotten. They each have input because of the extent of funding that they provide. So if the California Department of Public Health says, this year we want emergency preparedness as part of what our funding supports, then emergency preparedness would be on the survey. Right now I think there's a lot of priority being placed by a lot of funders on healthcare reform. The Department of Mental Health, the funding that they've provided has increased the amount that we ask on mental health issues, which was Spartan in a couple years, and it's now fairly comprehensive. The other limitation is it's a telephone survey, so it does need to be limited to about 30 to 35 minutes. So everybody has an issue they want on. I know I've got my set of pet issues, and I always say, well, can't we ask something more about this or that that's aging related or immigration related? And to add my question about people going to Mexico for health care means that some other question has to be dropped. So there's a complicated dance that looks at how many people are affected by the issue, how does it fall as a public health priority, what are the funders' priorities, and so forth. So emergency preparedness is definitely a possible issue. I don't personally know if there's anything in the wings about that. So the geocoded data, what's available for an outside researcher? Basically, anything that CHIS asks is available for an outside researcher. If you want to use the geocoded data, though, you have to use it through the Data Access Center. So that means that you personally cannot touch the data that has the geocodes on it, because that then leads to the risk of disclosure. So what you have to do, there is a process that's explained. Once again, go to the website, you go to CHIS. When you're on the CHIS website, there is information on how to request Data Access Center access. And you have to basically propose the study that you want to do, define the variables you want. It goes through a data disclosure process to make sure that the data that you will get is not identifiable. And then you work with the programmers here at the center to define the variables that you need and the output. And the programmers are well-versed in SPSS, SAS, and data, so whatever you're working with, if you actually do write data code yourself, or if you just want to say, I need output that shows how many people are more than 3 miles from a primary care provider, here's the list of primary care providers that they can do that data processing for you. Is it possible to get health information specifically for people above 65 years of age? Yes, the Data available both on the public use file as well as on AskGIS has a variable for age, and it is age by individual, well, on the PUF it's by individual age. So if you wanted 60, 62, 65, 70, you could define that. On the AskGIS system, you can either look at a variable, it asks for the health topic you want, and then the compare by, you could compare by age, and there are predefined age groups. Or you can define a population, which is sort of a third level of the crosstab. And then to define the population, you can actually put in any age that you want. So you could put 65 and over, and so all of your crosstabs would only be for people age 65 and over. For the AskGIS data, particularly through the data query system, like I say, we do offer online trainings, and we offer some in-person trainings. So I encourage you to sign up for our newsletter. We do announce those 2 to 4 weeks ahead of time. And we go through how to use the AskGIS data system very carefully, step by step. Any other questions? I think
So while we are waiting, maybe for one last question, I just wanted to clarify, yes, we will have a recording of the webinar available on our website shortly. Seems there are no more questions. So thank you very much, Dr. Wallace. We will continue the conversation with a special webinar next week on March 23rd. On the 1-year anniversary of the passage of the historic Affordable Care Act, Dr. Jerry Kominski will discuss the topic, Healthcare Reform, Where Are We 1 year later and What Hurdles Lie Ahead? For the regularly scheduled monthly webinar, please mark April 20th in your calendars. Dr. Hector Rodriguez will talk about innovations in delivery systems research, which promises to be another hot topic. Thank you all for participating. Thank you for your patience with the little technical glitch, and have a wonderful rest of the day.